Hi everyone, welcome to Pat Demystified. I'm back again with a lot of exciting stuff lined up for you guys. For today's topic, we are going to read a little bit about retinoblastoma. I'm Dr. Shubhika Sachdeva and let's dive into this interesting topic today. The incidence of retinoblastoma is around 1 in 16,000 to 18,000 live births. It is the most common intraocular malignancy of the childhood, which accounts for almost 3% of all the childhood tumors. It usually arises from the photoreceptor cells of the retina and it is usually diagnosed at the age of 16 to 24 months. So, what is the pathogenesis behind retinoblastoma? Let's dive into it. 40% of retinoblastoma show a familial autosomal dominant inheritance, and approximately 90% of these cases are bilateral. These children also are at an increased risk of developing other malignancies such as osteosarcomas, soft tissue tumors, and pineal gland tumors. When associated with a pineal tumor, that is a pinealoblastoma, these tumors are known as trilateral retinoblastomas. Whereas 60% of the retinoblastomas occur sporadically, these cases are usually unilateral and patients are not at an increased risk of developing other cancers. The pathogenesis of retinoblastoma is quite interesting. Retinoblastoma gene is located on the long arm of chromosome 13 on the location band 13q14. The retinoblastoma gene codes for the retinoblastoma or the RB nucleoprotein. This gene is a tumor suppressor gene, as the name suggests, tumor suppressor. That means these genes normally will apply brakes to the cell proliferation. If these are abnormal or mutated, the cells will proliferate uncontrollably. There will be failure of growth inhibition. There are two most important tumor suppressor genes that we need to know about. The first is the RB gene, which is called as the governor of proliferation, and second is the P53 gene, which is called as a guardian of genome. We'll read in detail about tumor suppressor genes and their functions and how they work in a separate lecture. For now, coming back to retinoblastoma. The two patterns of retinoblastoma, that is the familial as well as the sporadic, are explained by Kurston's two-hit hypothesis. This states that two mutations, which will involve both the alleles of our retinoblastoma gene, eventually leading to loss of both the genes, are required to produce retinoblastoma. So let us understand the two-hit hypothesis in both familial and sporadic cases. So what happens in the familial case? In familial case, one of the parents will be carrier of mutant RB gene. So eventually the child will have one defective RB gene and one normal allele of the RB in its germline itself. Now this becomes your first hit. These cells will proliferate in the stomatic cells of the child, and eventually in the retinal cells, the retinoblast will undergo a spontaneous stomatic mutation, which will become your second hit. And when this second hit happens, both the RB alleles are lost and the child develops retinoblastoma. Now, interestingly, in familial forms, this second hit is virtually inevitable. So, most individuals inheriting a germline mutation will develop unilateral or bilateral retinoblastoma, and this is inherited in a as an autosomal dominant trait. In contrast to familial cases, in sporadic form, at the germline level, both the RB alleles are normal. But in these cases, we know that both normal RB gene must undergo some spontaneous stomatic mutation in the same retinoblast in order to produce retinoblastoma. And the incidence of this happening in a general population is very low. Therefore, general population who do not inherit a germline mutation are less likely to develop retinoblastoma as compared to familial cases. So, coming on to the clinical features, how will the child present? The most common feature will be leukocoria, that is white pupil or white reflex in the effective eye. Other features can be glaucoma, strabismus, eye pain, decreased visual acuity, and in worst to worst cases, the child may present with an orbital mass. So, what will you see on gross examination? If you have an enucleated eye, what will be your findings? This tumor usually appears as a chalky white tumor which arises from the retina. It will have areas of calcification and some areas of necrosis. Typically, we see two growth patterns. First is the endophytic, as the word means, endo, coming inside. So the tumor in this case tends to grow inwards into the vitreous. And when it is growing into the vitreous, some tumor cells may detach and float in the vitreous, which is called as vitreous seeding. The second growth pattern is exophytic, that is, the tumor will grow outwards, and these cases will usually show non-rhegmatogenous retinal detachment. So the most interesting part, how will you see the cells microscopically? How will the tumor appear? So what will be the morphology of this tumor? So microscopically, these tumors can show both differentiated as well as undifferentiated areas. Now what do we mean by that? In undifferentiated areas, the tumor on low power will appear blue. Okay, so you will see sheets of blue cells, basophilic blue small round cells, which will be arranged in diffuse sheets or nest or trabeculae with some areas of necrosis. Again, in this picture, you can again see these blue basophilic cells which are present in form of nest. These unviable areas of necrosis, and this here is the normal retina. So on low power, you will see nest and diffuse sheets of undifferentiated small blue cells, and these are the viable tumor cells. Okay, and then here you will also see areas of necrosis, which will be the non-viable areas of the tumor. Now when you go to high power, how will these cells appear? See, now you can see that these cells are small, these are round, and they have a very intensely blue nuclei. So they are basophilic, they are intensely basophilic, and you can only see the nuclei, you can hardly make out the cytoplasm. So the cells will have very scant cytoplasm. Okay. So that was the undifferentiated pattern. Now the well differentiated pattern. The same tumor cells in a well differentiated pattern will tend to form, imagine a flower, okay. In other terms, in more scientific terms, you'll call it a rosette. So you will see these cells are arranged in a very beautiful ring-like pattern with a central clear space. So these are called as the Flexner-Wintersteiner rosettes. On high power, see how this has a central this is the subretinal space, which is the central empty space. This line here is the basement membrane, and these are the tumor cells arranged around this space, so in forming something like a flower, which is characteristically known as Flexner-Wintersteiner rosettes. Another characteristic feature of this tumor is presence of dystrophic calcifications, and again you can appreciate this Flexner-Wintersteiner rosette over here as well, and you see how blue the tumor is looking. These are the viable tumor cells, these are the necrotic areas, and this is the dystrophic calcification. Another type of rosette called as the Homer right rosettes. Less commonly these are seen in retinoblastomas, you can see them, but these are more characteristic of neuroectodermal tumors such as neuroblastomas or medulloblastomas. And how do you differentiate these from Flexner-Wintersteiner rosette is that they'll not have that central lumen, that empty space like here. these rosettes will not have. I'll have a different small lecture on rosettes separately. So to sum up, we saw microscopically that these tumor had diffuse small hyperchromatic basophilic cells with very scant cytoplasm, which were arranged in diffuse sheets, nest, rosettes, and typically these cells are perivascular, and they have areas of necrosis, which is the non-viable areas of the tumor, and characteristically you will find areas of dystrophic calcification. Now, why all these features are important? We can grade this tumor into 4 grades depending upon how, which feature is more in the slide that you are seeing. So histologically, these tumors are graded as grade 1 when you will see more areas of retinocytoma, that is neural differentiation will areas of neural differentiation will be there in more than half of the tumor. Grade 2, when you will see many rosettes, whether Flexner Wintersteiner rosettes or Homerite rosettes in more than half of the tumor. Grade 3, when you will have occasional rosettes. And obviously grade 4, when there will be only undifferentiated areas, there will be no rosettes, there will be extensive areas of necrosis, cells will look bad, and they will be arranged in diffuse sheets. So, what is the treatment of retinoblastoma? Just a few words about it. Earlier, the only line of treatment was enucleation. Now, as the science have developed, there are advances, and now the first and foremost treatment is to reduce the tumor burden. So we give selective chemotherapy to the patients through the ophthalmic artery. Followed by that, we give laser treatment or chiropractic in order to obliterate the tumor itself. If this doesn't work, then we resort to enucleation. So that was all for today. I hope you liked the video. Do not forget to share, subscribe, and put on that notification bell if you want to see more videos. There are a lot of exciting stuff coming up for you guys in upcoming few weeks. So stay tuned. This is me signing off. Bye and have a good day.